really a huge asset in our community and helping us think about how kids are moving in and out of these acute services. So, Dr. Scharf, I'll hand it off to you.
Great. Thank you very much, Melissa. And once again, just want to say it's great to be here today. I'm going to start my slides. I probably should have started this process while I was being introduced, but bear with me while I share the screen. And there we go. Are you guys seeing that in the regular slideshow mode or in presenter mode?
We are seeing regular slideshow mode.
Perfect. All right. Well, I don't have any disclosures to to highlight, but I there are some disclaimers or background information that I think are essential. First of all, the this is the content I'm going to talk about here. I'm going to use some terms that are generalizable across the state, but it's really with a regional focus. And the intention is to think about how to engage with mental health treatment providers and systems, and to do so effectively, and how to sort of put into a broader context the systems you're engaging with, the services, students you're working with are receiving. And the biggest disclaimer is that we talk about, I fall into it and talk about there being a mental health system. We just heard about an advertisement for Ann Sullivan's town hall about the public mental health system. There is not one system. That's a myth. That's a useful shorthand, but it's not accurate. There's actually multiple different systems with their own rules, their own uh, scopes, sort of definitions of what the boundaries are of what they will provide. And it can unfortunately create significant confusion, and sometimes even conflict about, who's supposed to, even before doing something, who's supposed to even hear about or be present for a discussion about the needs of a given child or family. But the positive side of that is all of these silos were created with the intention of providing better care to a vulnerable population. I'm going to try to expand on that, but just like anything, there's pros and cons of every approach. So the same silos that can be so frustrating can also be the sources of some of the best resources for kids and families for whom it's a good fit. So there are some acronyms, some initials that summarize the names of some of the agencies. These are the ones that I think I would use the most commonly in conversation and certainly in this presentation, including our Office of Mental Health. And again, the town hall ad was about an Office of Mental Health view of public mental health. Uh, we also will engage with Department of Health Systems. OPWDD has been the name for this office, that is Office of Persons with Developmental Disabilities, for long enough now. I think it's been a whole generation. Most people probably don't uh, have working memory of MRDD, given the evolutions of how we use terminology. But these were some of the old names. OPWDD, which is a mouthful, is the current correct term. OASAS, typically pronounced Oasis, is about substance abuse services, and then OCFS, Office for Children and Family Services, who sort of control the front door and regulate many of the supportive systems, and particularly with residential care that children and families access in our state. Now, what I'm going to talk about today is mostly about what you might call uh, medicalized or medicalizable mental health care, meaning a language, and part of that's a reflection of how my own training as a physician, as a psychiatrist. I trained, I learned, I grew up, if you will, in models of talking about things from a medical perspective, and it leads to some terms which may not always be obvious, like everything being inpatient or outpatient, right? Everything's either in the hospital or not in the hospital. I'll come back to that in a moment. But the the perspective, when I say something that's medical or medicalizable, I don't just mean biologic assessments and interventions. I mean things you could bill health insurance for. And within that context, so think about like care delivered, we tend to think about it or organize it in levels of care, which is really about the sort of intensity of resources in the moment, not the severity of the condition you're treating. So I listed them on the slide. You've probably already been looking at it, but we can think about this in a broader sense than just mental health providers per se, starting with what many call the de facto mental health system, schools, primary care, the adult professionals helping and working with kids in their day-to-day lives before seeing a specialist or concurrent with seeing a specialist. And really, we've talked about this already, even before I started, but the importance of communication is can't be overstated. The idea of communicating with an open mind, if you're using words and you're not sure how the other person is using it, asking to clarify, um, and just keep in mind that the most people doing this work are doing the best they can. And if you don't understand why someone is doing what they're doing, you can usually ask them and get at least the start of an answer. It's also important to know that many of the agencies, including schools, have rules about privacy. And my general recommendation or suggestion of best practice is to try to be as proactive with releases and ability to communicate as possible. Even to the extent of in a new school year, if you're verifying someone's vaccinations, why not throw in a release to speak to primary care? And if you know they're seeing a therapist, release to speak with the therapist as well. I said that very glibly and quickly. I realize that can be a complicated idea, but again, I'm just trying to make the point of the essential nature of communication and that we can be as proactive as possible. Ultimately, in crisis, confidentiality is limited by safety. If you are concerned about an imminent risk of self-harm, of violence, then that supersedes any confidentiality rules that you might be concerned about to communicate. All right, going back to that de facto mental health system that the where kids spend the time in their lives routinely. The when we think about doing care interventions, obviously there's a lot of assessment, a lot of observation, and when kids have challenges academically, assessments and supports provided within the school system. Also in New York State, every child should have a primary care clinician identified, and in fact they do. Now, whether or not they really know them, how often they see them, that can vary considerably. But kids should have a primary care provider, and primary care providers for the last 15 years have been used to the idea of being the first point of medical contact for most children's mental health conditions. I'm not suggesting that's the perfect solution for everyone, but if there's a new concern and they're not able to see a mental health provider immediately, working with someone's pediatrician or primary care provider can be very helpful. And New York State has developed a system to support primary care so that pediatric clinicians can have real-time access to a child psychiatrist Monday through Friday at 9 to 5 and can get over the phone immediate consultation. So knowing about Project Teach, again, that's for pediatric clinicians. It's also a maternal mental health program if you're involved in supporting pregnant or women in the perinatal phase. But for children, it's a clinician-facing service. But if the primary care clinicians or the families of the kids who you know are going to see their primary clinicians don't know about it, you can certainly uh, clue them in. And the website on there is a number of resources, including some family-facing education materials and rating skills, things that can be useful. Now, when we start to sort of, again, thinking about it like levels, escalate to the next intensity of intervention, we think about our ambulatory clinics. And this would really, when we think about this as a level of care, this would include anything that you make an appointment for, you know, go to the appointment and then the appointment's over and you leave. The so this could be in private practice, it could be an organized clinic, and it could include individual appointments, family therapy, group sessions, appointments with therapists, with psychiatrists or medication providers. And there are some outpatient services that are specialized, like the Healing Connection for eating disorders, or tracks within clinics, if you will, or pathways for specialized intervention. But as a level of care, again, if you're making an appointment, go to the appointment, leave after, and go home. That's considered an outpatient level of care. And then when we think about what is the purpose, what is this is like our lowest in this hierarchy of intensity level for specialist mental health intervention, but it's also where the healing actually happens. When we think about evidence-based care, evidence-based intervention for mental health conditions, almost all of them are conceptualized, created, validated, and implemented in ambulatory settings. Now, I'm stressing this point because people sometimes intuitively, and I understand it, feel like, if someone's trauma burden is really high, if their level of suffering is really high, the serious of their mental health condition is really high, then they must need the highest level of intensity, like inpatient. But in fact, inpatient is organized around in the moment, how much hands-on or supervision do you need? The actual healing really happens in the outpatient setting. And it's also important to recognize if you are referring someone or they're going to like an emergency room or an inpatient admission, the purpose of that admission isn't actually to fix, it's to stabilize enough to go back to the outpatient setting or to be connected with an outpatient provider, again, to provide the real transformative care. Um, Collaboration with outpatient providers is as essential with everything else. If you're connecting with a clinic, there's often a primary clinician identified, a therapist, sometimes it's a case manager, sometimes it might be Gerard, who's on the call right now. And that could be the contact person, even if you wanted to communicate with or get information from the psychiatrist or someone else on the team. And the utility of the communication can't be overstated. Again, we talked about the hours of time in one's life, kids at school, a therapist who sees a kid for an hour every other week just doesn't have access to the same quantity of observation and information. Uh, Probably the most important tips and things that people don't think of that you might want to when communicating with, collaborating with therapists is first of all that we use these terms generally like outpatient, like psychotherapy, but all psychotherapies are not the same. And you don't need to like learn every type of psychotherapy to be an effective collaborator, but it doesn't hurt to ask a therapist what kind of therapy they're providing. And again, not because you're going to criticize them or say, oh, I think you should do something else instead, but as a lead into the next question, which is, so how long would you do that before we expect to see a difference? Because some people have the idea, and this could be in any place, it could be professionals in schools and other settings, the parents, the kids might have an idea that, one visit or three visits and everything will be fine. Or they might have the idea that, it'll take years and years, but it might be a 4 week, a 4 month intervention. So having a conversation about what to expect, when to expect changes, or rethink the plan is really what I'm getting at with that. Um, Escalating, next would be intensive outpatient programs. We don't really have live intensive outpatient level of care available in our region right now. The in terms of accessing this for kids that you work with, Charlie Health is an online and entirely virtual service that provides this level of care. That's really the only way to access this specific level of care right now for general mental health concerns. But the Healing Connection has an intensive outpatient program for eating disorders, and it's very specialized. And the idea of this is still the same types of interventions as I was describing in outpatient, but more of them clustered together. So like 3 or more visits in a week of different types. Escalating another a step of intensity would bring us to partial hospital. And again, we're caught in that language of everything's hospital or not hospital. The idea is basically historically all the therapy, all the treatment that you could get in the hospital, but you go home at the end of the day. And in fact, it's more treatment and more therapy than you can get in the hospital. And so this again, it's still short term. It's not the long-term change that you would look for in an ambulatory treatment, but it's instead of like the inpatient hospital might be a week or less, the intention here is 2 to 3 weeks, often focused around a crisis. Most frequently, it's around suicide risk. But it's a day program. School happens there, and it goes on a school schedule, 7:30 to 2:30, um, 5 days a week. And again, this is about addressing an acute issue to get someone in a state where they can return to sort of an ambulatory level of treatment and return to their regular day-to-day at school. This is something that would be a referral, usually from a clinician, a therapist, but it could be from an ED or from a crisis clinician. Um, this is the biggest challenge with partial hospital in terms of expectation versus reality is often attendance. It only works if the kids are there, and if a person's biggest problem is school refusal or avoidance or challenges getting to school, that could be a challenge with partial hospital as well. We do find that most districts provide transportation, and we certainly problem solve if transportation is the issue. But that support with schools providing transportation with making sure kids can be there is really essential. Communication with schools should be routine, and I'm confident that at least at the level of the teachers getting sort of a academic handoff that happens with every case. If you are concerned that it's not happening with someone that you know is in partial or has just been discharged from partial, that's actually important enough that I would welcome contacting me directly or the director of that program directly. Uh, and then the last sort of, there's more than one slide about this, but sort of cluster of levels of care would be inpatient. And as I already alluded to, the idea of inpatient, again, crisis focus, it's really about immediate safety. It's a locked environment. The average length of stay is 7 days. We have a variety of services that people get while they're there, but the goal is stabilization enough to be treated in a lower level of care, not to completely fix the problems that people come from. And that can be hard to internalize or sit with sometimes, but that's the nature of the system that we have. This is typically most commonly accessed directly through the emergency room, and our inpatient unit at Strong is the only one in the region for kids. It can also be accessed through Brighter Days Urgent Care, and we can do direct admission from other hospitals and other emergency rooms as well. The pace and the timing of this means that the communication can be logistically more challenging, but everything I said about partial hospital in terms of our intentions and the importance of communication applies here as well. Longer term hospitalization would be what the state calls intermediate, which is 30 to 90 days. And long ago, again, more than a generation ago, New York State declared that children are not constitutionally capable of needing longer term hospitalization at inpatient units. And so there doesn't exist. So if someone needed longer term supervised mental health setting than the intermediate, which is at a few of our state hospitals in the region, Elmira and West Seneca are the closest. If a kid needs longer than that, then that would be an RTF, or residential treatment facility. Now, RTF is a mental health placement. It's the replacement for long-term hospitalization. RTC is Residential Treatment Center. That's actually a Children and Family Services placement. And that can be accessed through court, through county DHS, sometimes through schools for that's not that common, but for very specialized settings. But the main distinguishing point is while there's mental health supports in RTCs, particularly for the ones that are specialized, it's not a mental health placement, and there is much less quantitatively than you would see in an RTF. No residential units are locked, and that can present a challenge sometimes depending on where it's located and the individual kids' challenges. And they all have the goal of returning home. There's no residential, no model of care And again, it's axiomatically there can't and won't be for a permanent placement or a placement through childhood. All placements are intended to be back home, and the goals RTFs and RTCs have now are 9 months or less. And that's deliberately knowing that we still often end up on a year cycle. Now, I talked about this escalating levels of care. Of course, there's other care. There's emergency services like CPAP, like crisis phone lines, like our Brighter Days urgent care. And those are all activated in crisis to figure out what to connect someone with or do. Sometimes interventions can be provided directly in those services. But again, they're about triage, connection, sometimes immediate intervention, and then the connection to a longer term level of care is what happens. I want to specifically call out our Brighter Days Pediatric Mental Health Urgent Care. You've probably heard about this already. We opened in um, July of 2024. It's helped our region a lot already just in terms of flow and less kids going to CPAP. It's a much more benign child and family centered environment than an emergency department. Open 7 days a week. I'm uh, I'm already pushed past my allotted time, so I'm not going to go into more detail now, but we can certainly talk about that in the future. I can answer more questions. And of course, there are other services as well. This was intended to be sort of the 10,000-foot view and better define these levels of care and intervention. There are other programs for in-home services, case management, respite, but none of those are intended to be sort of the delivery of the healing. Those are all supportive extra things to facilitate the healing. And even when I use the term extra, sometimes they're critical and necessary. All right. That is my slides. I apologize for running a bit over. Um,
Oh, and Dr.
hope it
Sharp, we're
wasn't
going to
fun.
also have representation from both Yates and Seneca OMH, who's going to be talking about their local system of care. I'm
Fantastic.
wondering if folks on the call have a brief question or two before we move into the really excellent case presentation for today. Anything that comes up for Dr. Sharp and think about how to navigate this?